Yikes, it is bright in here. Well, can't really help the brightness. This is the best I got. So, let's actually get to writing a narrative. And I've taken the liberty of pre-writing the one that we're going to do, but I want to do it with you. So I wrote it out to save time, to make sure it was accurate. And let's go through it. So, if we're going to use the SOAP method, now, this is going to seem like a lot. And it is at first, until you get it down. It seems like a lot. But usually, typically, my reports take me 10 minutes. 10 minutes. Because, over the years, I've learned how to do them faster and faster. Just get more efficient with knowing what I want to say and how I want to say it. But in the beginning, it takes quite a long time. So I would say don't spend a whole heck of a lot of time trying to perfect it. Just work through the process. But I wouldn't stress out too much about writing these perfectly. But definitely, give it a good try. And I believe we'll work with you on that. So, and I want to add a few things to the SOAP chart. I could just call this SOAP format because we're not talking about chart right now. We don't have time. I'll do another one on chart if you guys wouldn't want me to. Up there with the chief complaint, I want to put in secondary complaints and then pertinent negatives. And those are things like the patient denies, right? So the chief complaint for this lady could be difficulty breathing. And I would put in there, difficulty breathing due to tongue swelling. So I would say the chief complaint is both things. There's no rule that says you can't have two chief complaints, right? Like, says who? You can have two chief complaints. You can say, my tongue swells and I can't breathe. It's not up to me or any other paramedic or doctor to say, well, you have to pick one that's worse than the other. No, I don't. I'm a human being and we live in a free country. We can pick how many ones we want to have as our primary chief complaint, right? But let's say you had other complaints. Let's say you were feeling nauseated as well. Well, there'd be a secondary complaint. Patient also reports nausea, right? And then pertinent negatives would be things like patient denies headache, dizziness, chest discomfort. I typically list the big ones, and I start from a top down just to help me keep it organized in my own head. And so I'll go headache, dizziness, chest discomfort, difficulty breathing, and nausea, vomiting. That's in trauma. I'll do trauma, no recent illness or injury, no medication changes, and no abnormal recent stress. I'll say stuff like that. And the reason I've added those is over the years, they've proven important bits of information. But I'm getting ahead of myself. And then the other thing that I'm going to add, I totally forgot to add, in the assessment is the your differential diagnosis. Now, or your field diagnosis. We don't diagnose. We're not licensed professionals, but that doesn't go under plan. That's going to go under your assessment, or it could be its own little thing. And DX just means diagnosis. But we do formulate a working diagnosis, a field diagnosis. And that's basically kind of just saying what protocol are we going to choose to go under. Because keep in mind, we operate off of protocols. We don't operate off of our own intuition. We operate off of a set of rules that physicians have laid out for us that said, yes, under these conditions, in this circumstance or these situations, you can do these treatments. It doesn't list treatments we can't do. That just kind of goes without saying, right? It's called our scope of practice. So everything that falls under the EMT scope of practice or the paramedic scope of practice is fair game for our medical directors to allow us to do. And they can kind of pick and choose what they want to allow, right? So those are the things that we're going to add. So the differential diagnosis would get added under the objective findings, and the secondary complaints and pertinent negatives would fall under the chief complaint, under the subjective. So let's write this lady's narrative, or that. And I've already done it, so here it is, but I'm going to write it with you. And what can help you to get through this is if you set your document up ahead of time. And as you're learning this, organize it. Who cares if it's not perfect? You're in the process of learning how to do this. So I've already organized this for you. And I'll put these notes up online. I'll make this available to people so you can look at this if you'd like. But look at how I've set this up. I've clearly identified my subjective matter. Under that, here's room for my chief complaint. I've got room for my history of present illness with those components of it right there, nice and organized. Past medical history, that's part of my subjective, which is what she's going to tell us. And then we organized our objective. So my general impression of the patient, we're looking for any major life threats. Here's our physical assessment. And then we have what we would like at minimum with 3 sets of vitals. So we get a good trend. Again, vitals are only as good as how many you take. One set of vitals really doesn't tell us a whole lot about the patient. It can, but it doesn't really. It's better if we get multiple sets, at least 2. It's preferred 3. When I was a brand new medic, I made a rule that I got a set of vitals immediately on scene, immediately once I got to the back of the ambulance, and then right as we were pulling into the ER, I would get another set. So I had 3 complete sets. And I made myself stick to that rule for a couple of years until I could organize my own time in my own head without getting too distracted. And then we have a place for our differential diagnosis and then our treatment plan. And we could break this down into, let's take away the bold and the underline. We could break this down into on-scene treatments, during transport treatments, and upon arrival at the ER, right? So we've organized this. So now we can start to write it, all right? And this can act as a guide, right? So chief complaint, patient reports difficulty breathing due to airway swelling, right? So there you go. There's her chief complaint, right? Due to airway swelling. How about tongue swelling? All right. So there we go. Now I could write in here, there's really no secondary complaints, but maybe she's saying patient also complains of difficulty swallowing, and throat pain, right? Because I'm guessing that if you have a big swollen tongue, it's probably going to hurt, right? It's going to be pushing on the back of her throat. It's going to be making it hard to swallow effectively. That could add into how long has it been since she's had a good meal, right? That could compound into, does she have any kind of, if she's a diabetic, has she had a hard time eating any food today, right? We'd worry about that. So history of present illness. So we could say onset, patient reports swelling began several hours ago and has worsened gradually throughout the day. There you go. Now provokes is a really neat thing that we're going to say provokes the difficulty breathing or the airway swelling. We could maybe say that patient states she gets increasingly, short of breath upon exertion. There you go. Might make sense. Quality. Is she going to describe the pain? I don't think there's much I'm going to put in there to quality, right? And radiates. There's really nothing she's got. It's not like, hey, does your throat pain radiate anywhere? It doesn't really make any sense. Does your difficulty breathing radiate anywhere? That really doesn't make any sense for this patient. We could also say patient denies other pain or discomfort. We could say that. Right? That's a pertinent negative, essentially. Right? Oh, shoot. Forgot my pertinent negatives. Patient denies what's some important ones. Dizziness. You might feel dizzy if you can't breathe very well. Headache. Sure. Chest discomfort. That's a big one. Abdominal pain. Nausea. Patient also denies recent illness or injury. medication changes or increased stress. These are big ones, and honestly, it's hard not to write them the way I normally do. And this is stuff I'd normally put in my charts. So severity, we can absolutely do this. Patient rates her difficulty breathing at 8 out of 10. Patient rates tongue and throat pain at 9 out of 10. Or you could say maybe it's not that bad. Maybe it's 6 out of 10 pain. Time, patient states this developed gradually throughout the day. Okay, so there we go. So we got a pretty good, and you could always say, instead of question marks, maybe put in N, A, right? Or you could say patient states the pain in her throat is sharp. There's really not much I'm going to put there. Allergies, I didn't really get a good listen to Mark when he was interviewing her, but let's say she's allergic to penicillin. Penicillin, right? Medications, we know she takes lisinopril. Lisinopril. That's what she's actually reacting to. Let's say she's also got AFib, so she's taking ASA. Let's say she's got metoprolol and simvastatin, right? It's past medical history. She's got some CHF, maybe she's got some high blood pressure, high cholesterol, and AFib. Let's say that. I don't know her medical history. Last oral intake, breakfast prior to tongue swelling. Events leading incident, really kind of know already. We don't need to, and again, if something's not applicable, you don't need to put it, right? All right, we got 3 minutes. I can do this. General impression of the patient. So we have, patient is let's call her 60-year-old female. Now where is she found? She's found sitting inside her apartment, and I'll say with fire department on scene PTA, that's prior to arrival. Patient is AO times 4 with anxious behavior. No neurodeficits noted, right? I'm not seeing any, right? Primary assessment, airway, EMS notes significant tongue swelling, no stridor noted, or other abnormal airway sounds noted. That's very important. Breathing is labored due to tongue swelling. Patient speaks in 2 to 3 word sentences, or 2 to 3 words per breath. Lung sounds are clear and equal. Circulation, strong regular pulses. No trauma, bleeding. Skin is non-pale, warm and dry. All right, I'm gonna keep cruising here. Head, tongue swelling causing airway, causing partial airway occlusion. Neck, normal's fine. Chest, clear, equal. Lung sounds, we think difficulty breathing, noted accessory muscle use. Abdominal pain, normal. Extremity, normal. Ooh, spine, normal. Vitals, again, blood pressure, all that stuff. Differential diagnosis, we're going to kind of scooch ahead. Drats. I'm going to do this quick. Diagnosis, anaphylaxis. On scene, patient is assessed with vitals, physical assessment, Benadryl and Epi. I'm not going to have time. Drats! I'll maybe do another one. There's the rest of my report right there.